My topic that was rendered to me by Nathaniel is minimizing blood loss, a key pillar in bloodless medicine and surgery. And again, you all recall the surgical pillars for patient blood management, which include, again, the preparation of patients by increasing their red cell mass, minimizing blood loss. Again, we think of it in terms of the surgical blood loss, but you'll see that there's more to it than just surgery. And third, of course, is supporting the patient through, again, treating and, again, making sure that the anemic patient is not compromised during the time that we're treating the anemia. And the pillars for bloodless surgery, bloodless medicine and surgery, as you could see, include these three pillars, but then looking also at optimizing tissue oxygenation, which may be part and parcel the issue of supportive physiological intolerance of anemia. So going back to the topic at hand, you could see in terms of minimizing blood loss, I've given you sort of an overview on this slide. And I think that it's always good to refresh our mind of what is bloodless medicine and surgery. Again, I think that it's important for everyone to understand, and I hear again from the previous talks that it's some individuals who are not familiar with bloodless medicine and surgery think of it as a highly unsafe or dangerous approach to patient. But again, I think it's important for us to reiterate that this is not a deadly approach to care. And then moving on to preventing or minimizing blood loss. Again, this is not a universal effort. We still have ways to go, not just in terms of bloodless medicine and surgery, but for the whole situation in terms of healthcare across the globe. And then look at some of the recommendations in terms of how to minimize blood loss, mostly during surgical events. But as I mentioned, we can't restrict ourselves to the operating room, because whether you're undergoing surgery or not, you're at risk of other blood loss through your hospitalization. And then looking at some specific in terms of effectiveness, and then a salary. So again, we have to remind everybody the definition of bloodless medicine and surgery is to improve patient outcome with the use of clinical strategies for their medical and surgical care without the use of allogeneic blood products. We probably should change that to say blood components. But again, as you could see, the flag is up in terms of making this a multidisciplinary approach. We need to always think in terms of our colleagues that have a stake in terms of the recovery of the patient and getting the patient through safely. And they need to be at the table, and they need to have, again, as we say, a vote, but the vote has to be a positive one, not just saying we can't do it. It has to do how do we do it, and how do we do it safely with the best outcome for our patients. So again, looking at some of publications that we have, I put up Nicole Gwyn's from Duke, looking at the costs and outcomes after cardiac surgery in patients. Again, this is old terminology we're using. We like to call it declining transfusion compared with those who do not. This was a case match study. And I highlighted again that this is not a large study. You could see 45 patients having cardiac surgery matched to 2 controls having same surgery. So 1 to 2 match allows you to, again, do what is considered to be a significant trial with less number of individuals within the experimental side, or the side that you want to look at in terms of outcome. And you could see that the scores were the same in terms of comorbidity, but there was no significant difference in total cost for witness and control. There was no difference in terms of ICU length of stay or total length of stay between the 2 groups. So again, it shows that with the effort of putting together a program that allows you, as a multidisciplinary program, that allows you to get these patients not just safely, that their outcome is at least equivalent, although we have some data which shows that their outcome is actually better. But I think that we need to be careful in terms of of that, but equivalent, I think, is just as good as we can get at this point. And if we have better, it's just it's an additional additional positive thing. So again, they concluded that utilizing blood conservation measures, cardiac surgery will be performed with similar outcomes and cost versus control. So again, we're talking about conservation of blood, patient's blood, which is important. Again, this one was published in 2016, so this is a relatively mature trial, but this looks at the outcome of protocol-driven care, critically ill, severely anemic patients for whom blood transfusion is not an option. Again, this is the correct language, if you will. And again, you could see that there is a 1 to 2.5 ratio in terms of experimental versus the control. Again, transfused patients were slightly older, had a higher hemoglobin level at admission, so that may have been actually something that may have countered the deficit in terms of age versus the increase in hemoglobin. It had slightly higher Apache score, but again, the Apache score is a range, so keep in mind it's a measure of the patient's underlying morbidity, but at the same time, you could see that you could have a higher score, but if you're still in the same category, the score is there to predict, if you will, for lack of a better word, your mortality risks. So the fact that you may have a score that's 33 and somebody has a 38, you're still within the same mortality range. So it really doesn't matter in terms of the score. We could just have said they were the same, but I think we have to be honest. Hospital mortality rates were 25% in the bloodless patients and 25% in the transfused. Again, so you could see the equivalence is one where we really want to advertise, but in the back of the mind, we always want to see if there's any better outcome in patients. And again, I think that that's just added, as I mentioned already, that's just an added positive thing. There were no significant differences in ICU readmission of positive blood culture results, meaning again, looking at risk of infection. What I'm showing you in this is the low hemoglobin in between the two groups and the mortality rates. And you could see that this is, again, scored against the different levels of hemoglobin. And what's interesting to us was that between 5.1 and 6 grams of hemoglobin, mortality was significantly higher in the bloodless versus the transfused population. And you wonder why, if you get below that there was no difference in terms of mortality between the two groups. And I will have to, again, this is ad hoc analysis, which I'm not fond of, but if you look for a reason, we could very easily demonstrate that the majority of the patients in that group had significant underlying malignancies and also were transferred from other hospitals where care was delayed for them. But otherwise, you could see that there's no difference in terms of mortality except for that, for that particular hemoglobin, level. Pollen is very high today. So again, bloodless medicine and surgery in the OR and beyond, and this is the perspective, if you will, or perspective of the American, this is the operating room nurses. And there actually we're addressing surgical techniques, but mostly patient education and also patient autonomy. So no matter what we're dealing with, we need to always remember that not just the patients need education, but our colleagues need education too. When we're bringing a patient into the operating room arena where there's considerable concern in terms of blood loss and recovery, but the patient's autonomy needs to be, again, constantly be reminded for everyone. Another publication that came out in the American Journal of Hematology, this was a critical review, treatment of individuals who cannot receive blood products for religious or other reasons. And this one, I think, came mostly from some of the Hopkins people here, but here they were talking about vigilance. Now, vigilance should be practiced in any surgical situation, not just in patients who are bloodless, but I think that maybe there should be a little higher vigilance in terms of intervention. But again, we believe strongly that every patient should benefit from what we learned from bloodless medicine and surgery, not just those individuals for whom transfusion is not an option. So here's some more data. The first one you could see says Delphi approach to the design of an interdependent blood conservation pathway for open myomectomy. So again, going to the GYN population, and again, looking at how we can conserve the patient's own blood. And of course, you could see that bloodless surgery and gynecologic oncology, this also came out of the Englewood group by Nimesh Nagershev. And again, pointing out some of the steps that need to be done to conserve the patient's own blood and making sure, again, that these patients get through surgery with a successful outcome. And then we had published, again, this early on publication in 2003, Surgery Without Blood, and again, bringing forward some of the techniques that are required in terms of conserving blood for these patients for whom, again, transfusion or blood components are not an option. And one of the tables in this 2003 publication talks about the contribution of selected techniques to blood conservation and surgery. Now, keep in mind that for the reader, it's rather than us putting it in terms of ml of blood conserved, we decided to put this in terms of number of blood units that would not be needed if the patient did accept blood. Again, it's not exactly the way we wanted to, but I think that makes it easy to read. So if you look at the different preoperative, intraoperative, and postoperative periods for patients for whom blood is not an option, if we look at the intraoperative approach, meticulous hemostasis and operative techniques, as you could see, these are referenced, by the way, the ones in brackets, at least one unit of blood, which we're talking about somewhere, again, around the 400 to 450 ml of blood can be conserved. This can make a difference between a hemoglobin of, say, 6 and 7, or you could put it in anywhere along the scale. Acute normovolemic dilution, depending on how it's performed, can reduce the blood loss by 2 units of blood. So we're talking about now between 750 to as much as 850 ml of blood being saved. And interestingly, blood salvage or cell recovery, we could certainly recover 1, and at times maybe even more, depending on the amount of bleeding. Of interest here is the postoperative approach to the surgical patient, where restricted phlebotomy is mentioned. So again, I think as you see from this particular table in 2003, we already had data, because of the references behind, that some of these techniques clearly leave the patient with more blood circulating in their arteries and veins than being thrown out in the operating room, if everything is applied. Now, each one of these alone is not as effective of all of them being done together. Now, this table, although it doesn't mention it, I would like to mention that this table is a product of work that's done by one of the most brilliant people I know, which is Zenon Bodnarak, who put this together for us and was instrumental actually in digging up some of the references to support this. So again, Zenon, thank you for this outstanding work. Now, here's another bloodless medicine, what to do when you can't transfuse. Again, you can see this is in Hematology in 2014. And they, again, talk about volume in terms of phlebotomy of patients, both pre and post-operatively, as well as the other techniques that are already mentioned. And again, they did not quantify what you could do, but I just put the arrows there to, again, stress the fact that there are techniques that we could use, and those techniques clearly are not, and I think we need to stress this over and over again, these techniques are not restricted to bloodless medicine and surgery patients. Every patient can benefit from them. So as mentioned here, you could see the issue of phlebotomy. And I think that deserves a few moments in terms of addressing this particular problem, which is pervasive across all medicine. So this is data from a large number of hospitals, 10 hospitals. You could see close to 200,000 discharges. And this is from the Cleveland Clinic, showing again mild, moderate to severe anemia. And it's defined in terms of hematocrits rather than hemoglobin, but you could do that math in your head. And you could see that, again, the prevalence of anemia is pretty high in patients coming into the hospital. And the distribution of mild to severe anemia is also pretty high. Mortality risk, as you could see, increases as your hemoglobin drops. Length of stay increases as your hemoglobin drops, and costs of your care also increase as your hemoglobin drops. So we know that the hospital-acquired anemia has a significant impact on patients in terms of outcome. And our colleagues in Europe, although this is old, this is from 2014, but it doesn't necessarily mean that it's bad. Again, our Marcel Levy over here writes that each 25 million liter of patient blood is thrown into the waste containers, sorry about the color, on an annual basis. So we're dealing with enormous amount of blood volume, which could be kept in the patient rather than doing tests over and over again. Taking you back to 1978, this is Rosenzweig's quote: "In today's medicine, bloodletting continues unabated. We have refined a technique, call it lab work. Jab the patient incessantly, generate reams of questionable data." And he was right then, and this continues to be in 2022. And bring you this data that was published by Lee and colleagues, looking at the repeated blood draws and the laboratory values as they relate to the care of the patient. And what happens here is that every day of the patient's repeated lab values, the significance of the information generated by laboratory is decreased by 20%. So at day 5, if you're doing the same lab values over and over again for 5 days, at day 5, the value is 0. However, what you will find is that the amount of hemoglobin that you draw from the patient is significant enough to actually cause anemia, which puts everyone, except for those who, again, decline transfusion, at risk of being transfused. There are 2 laboratory tests which are worth mentioning where their value is retained, doing them over and over again during the hospitalization. And one of them is, of course, a blood sugar for a diabetic patient who require control. And the other one is potassium in someone who's developed acute kidney injury. We looked at this just about 2 years ago, or less, actually less than 2 years ago, over a year ago. This was a narrative review on hospital-acquired anemia, keeping blood where it belongs. And again, we've shown that there was a significant number of attempts, if you will. This is the choosing wisely campaigns and recommendations from different organizations that deal with blood. And you could see again that everyone frowns on phlebotomy. However, The problem is that this behavior still continues unabated, as already mentioned from the quote I showed you before. And there's plenty of publications out there, again, to show that reduction of phlebotomy improves the patient's own hemoglobin, if you will, by, again, keeping the blood in their vessels rather than in the laboratory. So when we're looking at strategies to minimize intraoperative blood loss during major surgery, this is the British group that had looked at this. And again, you could see they're dividing their second pillar in terms of minimizing blood loss and bleeding. So to Nathaniel's point, here is a concentrated effort to try to identify the different entities that we can actually employ to reduce, minimize blood loss, and hence put the patient at less of a risk and improve their patient outcome. The strategies to minimize intraoperative blood loss is listed on this table, and you could see they're divided into organizational, surgical, anesthetic, and hemostatic. And I think to their credit, they really addressed everything in terms of those different categories that I just mentioned. But these are not always employed, number one, and two, when they're employed, there may not be good understanding, which I will address with you as we progress on this talk. Cell recovery, as you all know, is a fairly simple procedure to do, but even though I'm looking at the schematic diagram explaining what's being done, which I think is very simplistic, I think that the issue of cell recovery is that it's not available everywhere. And the equipment itself is not inexpensive. So there is a significant resource that's required to own those pieces of equipment. And in addition to that, the disposable pieces of this equipment may be, again, a hinder or a barrier for many places in the world where resources are limited. So in the face of not having cell recovery, I'm just bringing this up that there may be other modalities, which I will address with you shortly, that may make cell recovery in some way inefficient, meaning that you're not going to get what you want out of cell recovery. If you have it, clearly, as we mentioned already before, every single modality that is there to minimize blood loss independently can do that, as we showed in that table with the loss of units of blood. But all together, meaning if you use all of them in concerts, you're going to get the better impact in terms of minimizing blood loss. So as you could see, this is not reserved for publications, because from our side of the world. Here you could see Nathaniel's publication that talks about blood conservation and surgery, current concept and practice. And lo and behold, here again, the same table that was shown in 2003 is now again being used in 2011. And I think it's important because it drives the point over and over again that this is not just doing things without having some impact in terms of true conservation, that you can, and it's been again addressed, as I mentioned, in the literature, that these are actually real savings, and probably for many situations where there is a significant blood loss during the surgery, that these are probably conservative and may actually do better than what we're seeing. But again, keep in mind that doing all of them gives you the best results. So Nathaniel, thank you again for publishing this and resurrecting this important table from Zenon. Now, topical hemostatic agents, this is one showing you a publication that we had in Annals of Surgery in terms of cardiothoracic surgery, where I think they're mostly employed, although we're starting to see them employed in abdominal surgery and other specialty surgeries. The problem, of course, is the question of how to use them, when to use them, and when each one of them is most effective. And I'm not going to go into detail because of time, but just to let you know that in this particular publication, the attempt that we had, and as you can see, Art Bracey is the lead author here, is to first of all classify them in terms of their activities, so that educating the clinician, the surgeon, in terms of the use, directing them to the correct hemostatic agent rather than just using them arbitrarily because your hospital decided to just buy one. They don't work in all situations. So selecting the category is important, and that's why we built the left side of the slide. And then understanding where they're going to be effective and how to use them under the circumstances is also important. That's the right side of the slide. Now, I know this takes front and center stage right now, the use of hemostatic agents, specifically the antifibrinolytics such as tranexamic acid. I think, again, one has to keep in mind that anything that we use, it has to do with the fact that it has a benefit which is greater than the risk. However, if it's used indiscriminately, the risk now can rise to the point where it may overshadow the benefit. And in this particular narrative review, we looked at all of the large studies that were done, including the CRASH, the women's study, and we did a critical reappraisal, of its use over the last decade. And again, I think that one has to be very careful with the indiscriminate use that we currently have with tranexamic acid, because some individuals, and we really don't know how to identify them, that's the problem. So you need to look at the total clinical picture in a situation, are again, the use, they are, have a low fibrinolytic activity or sometimes zero fibrinolytic activity. And what happens when you give them an antifibrinolytic, they become now at risk of significant thrombosis. So you may get them through the surgery and you may have less bleeding, but at the same time, the outcome is going to be overshadowed with the risk that you may have introduced. So again, we're just warning the medical community that we need to find ways in which to identify those patients at risk where we will not be using some of these agents. And again, this late last year, this was published in Tranexamic Acid and Obstetric Hemorrhage, giving empirically or selectively, with again the same idea that one has to be cautious in terms of using antifibrinolytics. Now, I'm not going to address this concept of fibrinolytic shutdown. I think that that's a very controversial concept. So this is not what we're talking about. We're talking about the phenotype of patients, again, who do not need antifibrinolytic. Again, this is another publication looking at reducing red cell transfusion, orthopedic and cardiac surgeries of antifibrinolytics. So now we're looking at all of them, not just tranexamic acid. And again, when you use them according to this particular analysis, and this was a very large analysis done, and you could see Robert Thurr is in there as well as Erwin Gross. We came up with the assumption, again, as you always know when you do meta-analyses, it's an assumption that it favors, again, the use of antifibrinolytics in terms of reducing blood loss and hence reducing a transfusion. So this brings us to acute normovolemic hemodilution. And in this particular pie diagram, you could see that ANH really occupies a very small area in terms of blood conservation. ANH is a point of care blood conservation strategy, which is performed on the day of surgery. It's of course acute, so it's conducted relatively rapidly. It is normovolemic. That is extremely important to know because anemia and hypovolemia are a dangerous combination. So again, we have to preserve the patient's volume. Hemodilution is predicted response to the administration of acellular fluids, and it requires adequate vascular access. The process is the removal of patient's whole blood prior to the incision with a simultaneous replacement of crystalloid and colloid to maintain euvolemia using monitors in the operating room. Blood volume is diluted until the target hemoglobin is reached. And again, we're inducing anemia. It's a surgical blood loss, contains less. So when they bleed during surgery, they're bleeding less red cell volume. And whole blood is returned at the completion of the procedure, where last is given first. And this is just a schematic of the ANH procedure. As you can see, we remove the blood, we monitor the patient, replace them with crystalloid or colloid to dilute their red cells, and then, of course, return it back when it's done. So just to give you a basic principle, hemoglobin of 14 with an estimated blood loss of 1,000 ml of blood, you're losing 140 grams of hemoglobin. Again, if you dilute yourself down to hemoglobin of 8, you can see that the loss is significantly less, just about half. So you're saving 60 grams of hemoglobin that's kept at the bedside with the patient. And following surgery for critical moment, fresh autologous whole blood is returned. So again, it's the patient's own blood kept by their side. And again, it's a personalized blood bank, essentially. I'm not going to go through the history, but again, the history of ANH, it really started with heart surgery and trying to get extracorporeal circulation, and the need again for restoring some of the blood that was being shed. As far as knowledge of what the target hemoglobin, even if you reduce the hemoglobin, making the patient anemic, remember that the critical point at which oxygen delivery affects oxygen utilization is in a human being is somewhere at a hemoglobin between 4.5 and 5 grams per deciliter. So being at 7 and 8 gives you still significant margin of safety when we do ANH. And that was actually shown by our colleague, Dick Weisskopf, published again earlier in the 90s, looking at normovolemic anemia, a hemoglobin down from 13 to 5 grams per deciliter. Cardiac index, of course, rose, the heart rate rose, systemic vascular resistance dropped as you'd expected. The VO2 remained the same, maybe even increased a bit, but it's really statistically no different, and there was no lactate issues. These were healthy volunteers. But again, in patients going for cardiac surgery, looking at normovolemic anemia, an effect on cardiac work, and you could see that, again, there's a significant reduction in work of both the left and the right ventricle in terms of surrogate measurements of work activity of both ventricles are reduced with ANH, so it's protective. And another by Mark Licker, looking at, again, this activity of ANH in patients undergoing valvular surgery. And you could see again that not only it preserved blood, but also improved the blood profile by increasing erythropoietin. So again, the recovery is higher. And interestingly enough, also what we're seeing is that there's a reduction of tissue markers for cardiac injury associated with ANH. So it's protective in many ways. And here again, you could see the EPO levels are higher with the ANH group as compared to non-ANH group. Again, this was a meta-analysis and reduced the risk of infection. We don't know exactly if this is an association or causation, and may be due to reduced transfusions, or it may also be due to the fact that that may have some protective effect. And again, it's showing that there's a small but likely underpowered trials that have been used in the meta-analysis. So I think that the data that we have, or conglomerate data that we have, ANH is a very effective way of not only conserving the patient's own blood, but in situations where you don't have cell recovery. By the way, the more blood you can actually take from the patient during ANH, it will make the cell recovery, because it's so dilute, ineffective. So again, if you recall, I mentioned that early on. There are many consensus guidelines out there in terms of the using of ANH, but some of them are positive and others may not be supportive of ANH. But again, we at SABM produced the standards for best practice acute normovolemic hemodilution. This was, again, in conjunction with NATA. And this is for cardiac surgery. And we've had green, which is the clear indication, yellow, which again is recommendations too, but they have to be done on an individual basis. And of course, the red suggests that you should probably consider other modalities. And just to show you highlighted, I bring these up so you can read them much easier than looking at them in the background of the slide. So the challenges remain despite longevity and theoretical benefits. Safety and efficacy are still challenged. The efficacy, challenged by some investigators, never gained full acceptance, is a problem. The severity of anemia, ranges of blood collections, again, makes anesthesiologists uncomfortable. Clinician experience, additional work, absence of reimbursement, again, is underutilized because it's small work. Even though it's better for patients, may not be, again, utilized across the board. But for the bloodless medicine and surgery patients, I think this is not even a challenge. There's no option. So again, it's not a standalone procedure like anything else that we've discussed. A reduction of allogeneic transfusion requires a multimodal approach. ANH is an inexpensive, easily to perform technique that can contribute to patient blood management. So at the last moment that I have, minimizing blood loss extends beyond surgery. Again, require a team of multidisciplinary approach. Many techniques and pharmaceuticals are available. The problem is some areas may have, others are not. So you need to know the contribution of each one of those modalities to, again, stratify whether you have the resource or not, what you think is going to be the most effective in your particular area. One needs to be familiar and know when and how to use any of them, and each method has potential to save significant amount of blood, as we've shown. So pillar 2 is between pillar 1 and 3. Remember, we always need to, again, employ everything that we know in terms of bloodless medicine and surgery. So again, we can provide the patient with the best outcome.